All right. So if you want to just reduce the volume, that'd be great. So assalamu alaikum, everybody. My name is Dr. Hassan Mir. I'm one of the cardiologists who's assisting and coordinating this session. Thanks so much for joining us. I know we're a little bit behind, but we wanted to give everybody an opportunity to come in. I'm using this predominantly for the people in the back to ensure that you can hear me appropriately. But if you can hear me. Thank you so much. So we're going to get started. So as you know, we have about 50 registrants for the in-person live demo and practice. And then we've also got a virtual setup as well. So the goals for today, I'll do a brief introductory session slides, and then we'll go into the first part, which is more lecture-based, and then the second part, which will be more hands-on in terms of practice and what have you. So there's going to be people shuffling around in the back. So if it's ultra distracting, just kind of put your hand up and feel free to just let me know, or Hashim or any of the organizers know. So without further ado, we're going to start the Lifesavers 2022 program, which we're putting on as a collaboration with ISNA Canada, along with the Muslim Medical Association of Canada. So myself, as the co-director of medical education, as well as Dr. Hashim Khan, as co-medical director of education, and we've been in the role for several years. We actually did various collaborations with the ISNA community in past, and are very excited to get this one started. This is the first time we're doing this event in person, because we started this a few years ago during COVID as an online virtual event. So within the introduction, I just wanted to briefly discuss the agenda for the items, and obviously things are pushed down a little bit because we're starting about 15 minutes late. So we're just slightly, so we're just slightly behind by about 15 minutes, but I've built in filler time in here. So hopefully we should be okay to still finish around 1:30, recognizing there is another event coming up. So we'll do a brief introduction, and then we'll start off with Dr. Arif Naqvi, who is a cardiologist in Toronto, who will talk about stroke and myocardial infarction or heart attack recognition. Very important, especially within our community, recognizing the rates of heart attacks and strokes are somewhat higher in the South Asian, Middle Eastern community. So hopefully we'll hear from him on a very engaging talk. Next, we'll hear about choking from Dr. Hashim Khan, who is a respirologist in Toronto as well. And hopefully we'll review not just what to do if somebody is choking, but also talk about how you help them to clear their airway. The third will be on seizures and what to do if you happen to come across somebody who's seizing, and then how to approach them, and then what to do and what not to do, and then hopefully discuss the recovery position. And then lastly, myself and Dr. Shahab are going to talk about CPR and AED. So we're going to talk about what is a cardiac arrest, why it's important to know what CPR is, what is an AED, how do you use an AED. And then after that session, we'll take about a 10-minute break for bathroom or whatever else as we get things set up. And we'll have about 45 minutes or so to then practice with the mannequins that we have got, as well as the AED units that hopefully the first time you need to use them isn't in a real life cardiac arrest. You get to actually use all of the AEDs that are trainer AEDs, so you can't actually shock anybody, but you can actually use them and practice with them now. So God forbid, if you happen to come across somebody who's actually had a cardiac arrest, it's not a situation where you have never seen or used one before. And so after we do that presentation, we're going to do breakout rooms, groups, and depending on the number of people, we'll probably just pick randomly. But ideally, we would like groups of 5. And if we're expecting the 50 people that show up, we'll have 10 groups, and we'll have 10 small group areas where you practice with a facilitator to do whatever else. So we'll kind of discuss that at that point, and everybody should have sufficient time to go forth with that. So at that point, we'll conclude. We'll have about 10 minutes for question and answers. If you have any specific questions during that time, feel free to ask. For the purposes of time, it would be great if we can have the speakers have their presentation approximately 10 minutes each. And then after that, we'll have a 5-minute question and answer period. So if you can hold questions to that point, that'd be great. If you feel it's a really important, necessary question that needs to be asked, feel free to just raise your hand. It's pretty easy for us to see if somebody has a question. All right. So I'll start off very briefly about the importance of the basic life support. So I think all of you, recognize the importance, and it's great for you to attend a workshop like this. And hopefully, if you find it useful, then inshallah, as we hold them in future, there will be more attendance from other members of our community. So the more people are knowledgeable about this, if it happens to us, it happens to our family members, and we don't happen to be there, our whole community gets better as a whole in our education. But the importance is, as you can imagine, if somebody's having a heart attack or stroke, the sooner you recognize it and deal with it, the better, right? The sooner you call for help, the better. If somebody's seizing and somebody's trying to put something in their mouth, that's probably not appropriate, right? If somebody's choking and you don't know how to do the Heimate Maneuver, they're just going to be unable to breathe for several minutes when you could have potentially saved their life. And similar with CPR, majority of cardiac arrests happen outside of the hospital. So what are we doing in our community to be able to assist our brothers, sisters, citizens, etc., should we have to come across somebody? So extremely important. And obviously, I think it goes without saying, all of us know that, as Allah subhanahu wa ta'ala says in the Quran, just to kind of get to the point, that if you save a life, it's like saving all of mankind. And so we all have that opportunity, so long as we empower ourselves with the knowledge and the skills, which are very easy to learn, as well, as you'll see, then we can all, inshallah, have the benefit of what Allah subhanahu wa ta'ala promises us in the Quran. So just a few disclaimers as I wrap things up. So the hope of these sessions is not only the knowledge as we obviously use in the day-to-day medical careers that many of us are involved in, but also in the Islamic principles as much as possible. And if there are any mistakes, obviously we've vetted the content as much as possible, but if they're obviously unintentional, and inshallah, Allah subhanahu wa ta'ala will rectify them or shine light on them so we can correct them in future. And then the last point, just importantly, that this does not replace formal basic life support certification. This is important to know as a bare, entry or introduction to this topic, but does not necessarily, it certainly does not replace a certification through another organization, whether it's St. John's Ambulance or Heart and Stroke. So you will get a participation certificate, but that doesn't necessarily take away from the need for certification in future. And then lastly, I realized I forgot this in my in this section, which is important. We do have several other members, in addition to myself, Dr. Naqvi, Dr. Khan, and Dr. Khan, who are presenting, but we also have 4 other physicians who are supporting with the breakout rooms. So Dr. Raja, who's a cardiology resident at McMaster University, he's a resident physician. We have Dr. Saba Shahab, who's a second-year resident in the University of Ottawa in internal medicine, who will also be supporting me in the Cpr and Aed talk. We have Dr. Nabil Asrawi, who's a first-year resident at University of Toronto Internal Medicine, so another resident physician. And then we have Dr. Shaima Halal, who's a medical genetics resident in first years at University of Toronto as well. So I just wanted to make sure that everybody is appropriately recognized, and we'll try to get some name tags on everybody so you know who we are. All right, so without further ado, I'll kindly request Dr. Arif Naqvi to come up.
This is good. You guys can hear me at the back? Assalamu alaikum. Thank you very much, Hassan and Hashim and MMAC to put this up because it really is important for the community, and then to invite me. It's my pleasure to be participating in this. And the other thing I should comment, I'm really pleased to see the different age groups here, the younger people and the older one. We all have, it's important that everybody learn this, whatever stage of our life we're at. We all have somebody who's going to be exposed to a family member with one of these things. So if we have the skill set or the awareness, we can really save lives. So I think this is a really worthwhile effort that Hassan and company are undertaking. So the thing I've been tasked to do is to talk about how to recognize heart attack and stroke. So before we do that, know that in our community, heart attacks and strokes happen at a higher frequency than they do, let's say, in the non-immigrant or non-Desi community. So South Asians in general have a higher risk of heart attacks, higher risk of strokes, and we tend to get it at a younger age. So we have to be careful, and we have to know. And my talk is going to be non-didactic. It's going to be all, just feel free to ask any questions that you have. So just by show of hands, because I want to get people involved, how many know of somebody in the family who've had a heart attack or stroke? Just show of hands. Yeah, so usually I see even higher than that. In our thing, usually it ends up being about 50%. So somebody has experienced either father, mother, grandmother, or whatever, who's had a heart attack or stroke at home. And it would be really nice if you guys can assist in recognizing it. So any volunteers on what causes a heart attack or stroke? Come on, put up your hands. Yeah.
What do I know? Blood goes to the head.
Right.
For me.
Yes.
And there's head and down.
Yeah, close enough. So every organ in our body needs blood so that'll bring oxygen, right? And it comes in pipes. And so what cardiologists are, we're just glorified plumbers. If the pipe is plugged, then the blood won't go to that organ, and therefore that organ will be damaged because it won't have oxygen. Does that make sense? Fairly clear? So if the blood doesn't go to the brain, it'll cause a stroke. It'll cause damage to the brain. If the blood doesn't go to the heart, that's called a heart attack. Okay, so what causes that is this little thing here called so that's your pipe. I don't know if you can make that out. So that's a pipe, and that pipe is supplying oxygen to the heart itself. Okay, these are called arteries. They take blood to the organs. And this is pipes that are taking blood to the brain. So if that one's plugged, that's called a stroke. Because that area in the brain that they've shown by the blue mark here gets damaged. If that artery there is plugged, then that area supplied by it won't get enough oxygen and it'll get damaged. And that's called a heart attack. So fairly clear on those. And again, if anything's not clear, please just interrupt and ask. So what happens is our body has a little bit of time. The first thing so the question is, why does a blood clot form? Does anybody know why our body forms blood clots? Yeah, why does it form clots? You see these blood clots? Sure, that's what happens in the arteries, and that's actually a bad thing. But generally, we form blood clots because, let's say, an animal bites us, we don't bleed to death, right? So it's a good defense mechanism to have blood clots. But if we sort of get these plaque buildups, I'm not sure if this is working. If we get plaque buildup in the arteries, like there, then sometimes you'll form a blood clot where it shouldn't be. Okay, so that happens if we have a little extra biryani every day, or if our diet's not so good, if you're smoking or have high blood pressure. So if that happens, then you get this plaque buildup. Okay, and think of that as no different than any hair down a drain pipe. It starts to plug it up, right? And eventually a blood clot will form and it'll obstruct it. And that's what causes the damage. So when these happen, the most important thing is to recognize it. So anybody here know common signs of heart attacks? Come on, somebody's got to put up their hand. I'll have one of the doctors put it out. So yeah, go for it. Sure. Anything else? So we've all seen movies, people grab their chests and then they fall down, right? And that's fairly easy to detect. What are some of the others? Yeah, go ahead, sister. So discomfort in the left arm. Yeah, and often people are very sort of picky that it has to be the left arm. It doesn't. Okay, so anything from here to here, assume if it's, It's more the setting in which it happens, okay? And this I get a lot. And, you know, I get pain in this arm. Is that a heart? Is that a heart attack? Because all of us, we get pains in the arm from time to time. If you move and it hurts, it's not a heart attack, okay? So generally, you want to know it's a setting in which happens. If it's a sudden onset discomfort, so in the arm, this arm, in the chest, particularly if it's going up to the jaw, then it's probably something you got to take seriously. Okay, so again, if you this happened to a friend of mine, and the other thing I should point out is women in particular have slightly different symptoms than men. Okay, and women can have just nausea or just sweating. So they'd be sitting there and just have nausea, and that could be their heart attack. Okay, and again, you know, if you've just had bad Chinese food or something, and then you go home and have a little bit of nausea, that's probably okay. But if it's a sudden onset nausea and you start to sweat, then that probably is something you want to take seriously. Okay, does that make sense? I'm going to give you a little anecdote. A very good friend of mine, he is a family doc, and he was sitting there and they were eating, and his wife got nausea. And so he gave her Gravol and various other things, and ended up, she had a massive heart attack and she didn't make it to the hospital. Okay, so even doctors make these mistakes. It's important for us to recognize the subtle symptoms. Everybody gets a chest pain and crushing, but you don't get the, you know, the sudden onset of sweating, sudden onset of discomfort in the arms, sudden onset of nausea or vomiting, or dizziness, isn't it? If somebody faints, everybody knows pretty much that we got to get them attention, right? Okay. So the other thing is that once that clot happens, whether it be to the heart or to the brain, time is muscle or time is brain, okay? So we have to get that clot out of there to restore blood flow. Does that make sense? You got to get blood to the brain. So the sooner you do it, the less brain damage there'll be. The sooner you do it to the heart, the smaller the heart attack. If you get your family member to the hospital with a heart attack, there's a very, very high chance they'll survive, okay? If most of the deaths happen before they make it to the hospital. Okay, so that's where I really commend MMAC for putting this together, because it is important that we recognize that most of these deaths will happen because of a lack of awareness. Okay, so if you're having symptoms, come early. Now, so these are the signs of the heart attack we talked about. I think shortness of breath, sweating, nausea, dizziness, fatigue, unconsciousness. Anybody have any questions about any of these?
I got a question about
Sure.
blood clots.
Yeah.
Can we know this ahead of time? The situation of the artery pipes, if blood is going properly or not?
Yeah, so generally, if you have an artery blockage more than 50 to 70%, you can probably pick that up on stress tests and these sorts of things, but you have to look for it. There's no, so you can go to your family doctor, say you have a lot of family history. You might say, look, you know, I have a lot of family history and I have cholesterol, or I have high blood pressure, or I smoke, or whatever. And they can carry out tests to try and pick up some of these conditions ahead of time. But a lot of the heart attacks will happen to people without known blockages, all right? And so that's why you have to be careful. So a lot of the heart attacks just statistically will happen on blockages that are only 40%. And then the blood clot will form, and then it'll occlude it completely, okay? But that's a very good question. Yes, you are, if there is a family history, or if you have any of the risk factors for heart disease and you know of others, then yeah, go to your doctor and they will get you assessed and they'll look for it, okay? And we're getting better and better at imaging. So any other questions about the symptoms? Yeah, go ahead. That's a fantastic question. So the question is, for those who didn't hear, how did distinguish between a heart attack and a panic attack. So reality is that we shouldn't expect people to figure that out. Okay, if you're having a crushing pain or shortness of breath or dizziness or about to faint as a part of a panic attack, come to the hospital. They will do the blood test for you, an ECG, and they'll say, yeah, you know, sister, this was a panic attack and this was not a heart attack. And eventually you figure out your pattern. So the people who are anxious, they know, okay, when I get this chest pain in this setting, this is not a heart attack. But that only comes if they've come to the hospital a couple of times and they know this is, but always take the safest approach. So if you're concerned, come in and get seen. Okay? Sure. As I say, women tend to have slightly different presentations, a little more pain going into the back, a little bit more fatigue. Sometimes it's a sudden onset fatigue and just being sweaty. Those things are very important. So as soon as that blood clot forms, remember time is muscle. So you've got to try and get the person to the hospital, because what happens is if the heart is unhappy, if that muscle is being damaged, then sometimes it'll set up electrical problems and the heart just stops. Okay, and if that stops outside of the hospital, then that's trouble, because it's hard to do CPR and get them back. You still got to do it, but the hope is that we don't get to that electrical problem outside the hospital. The stroke signs, that's when there's damage to the brain, right? It'll depend on which part of the brain is affected. Okay, so that the front part is about our thinking. Then there's related to motion. Then there's related to sensing. There's related to balance. Is related to hearing. So different and vision at the back. So if all of a sudden you have a vision problem, that's not a good thing. You're not allowed to have an all of a sudden thing. So generally, if I can give you one idea, it's that sudden onset of new symptom. That is anything that you might think relates to your function, whether it be how you speak, whether you can't move the arm, or the sister mentioned the arm goes numb. If your right arm goes numb and your right leg goes numb, that's not normal. That's probably a stroke. Come to the hospital. If all of a sudden the face droops and somebody says, look, your face is funny, and you have to get that looked at. So the act fast, face, arm, speech, and obviously time is critical. Okay. So this is an illustration of, again, the importance of time. So suppose you block an artery that is supplying that area to the brain. Okay, usually within 10 minutes, you're going to start to see some damage to the brain. And they say, nah, it's probably nothing. I'm going to sit at home. And in an hour later, there's more damage. If you don't get to the hospital within 3 hours, probably we're not going to be able to help you to dissolve that clot too well. And then you'll get fairly significant damage. So for the heart attack, obviously come as soon as you can. For a stroke, you want to be in the hospital within the first 3 hours, probably a lot sooner. So in summary, it's important to recognize the symptoms of a heart attack or a stroke. It's really important that you recognize it's a sudden onset something, usually, okay? And it doesn't have to be that catastrophic thing that they show in the movies. It can be fairly mild, but you have to know that, geez, this is not me. This is not normal, okay? And then you have to react. And for the kids here, remember that if you see a family member who's doing this and you don't remember anything else, remember 911. Get help for somebody. Okay. Any questions? Okay, great.
All right. Bismillah. Assalamu alaikum, everyone. My name is Hashim. Nice to meet you all. So I'm a respirologist or a lung specialist here in Toronto, and I want to speak to you about choking. And I'm going to make this fairly short. You know, there's tons of slides and things, but I think where the most important thing is for community members, and what we're trying to drill down is recognizing when someone needs medical attention, and so whether it's having a heart attack or a stroke or is choking, what you can do in the moment to help them, and what you should do in terms of asking for help, whether it's calling 911 or getting someone else to help you, and then giving you guys practice to be able to do CPR. Because if you do CPR properly, you'll save lives, and if you don't, it may make the difference between whether or not your family member or someone beside you can actually make it to the hospital or not. It makes all the difference. Cannot understate that enough. So very quickly, when someone is choking, you have to respond right away, right? You don't have time to wait for like 20 minutes for the ambulance to come and help that person. So what do? We know that in Canada, 40% of injuries to little kids or infants under the age of 1 happens to people who are choking, right? So it's very, very common, 40%. And 9 out of 10 people who die from choking, that happens at home because you don't have time to go to the hospital. You can choke on liquids or on solids. Sometimes it might be temporary, or it might go down into the stomach, or it might actually go down into the lungs. And we call that aspiration, and it can cause a pneumonia and chest infection that way. And there's some people who choke and they'll just die from what we call, where the blockage is stuck there in the throat and no air is going down in and out of the lungs. You can't breathe and you die from what we call asphyxiation. I'm just going to quickly go over this. So what happens is, if you look over here very quickly in terms of the anatomy, so you have your nose over here, your mouth over here, your tongue over here, and over here is your throat. Okay, so normally when you're eating something, something comes in through your mouth, behind your tongue, and it comes back over here. And there's a passage in the front here, which is where your air goes, and there's a passage at the back here, which is your esophagus, or where your food goes. And there's a small flap over here called the epiglottis. And that flap over there is what helps decide, oh, what's coming in through my mouth? Is that air? Okay, it's going to go down into my lungs. Oh, is it food or water? It's going to go down the back to my stomach. So a lot of it depends on what this flap is doing and if this flap is working properly. Okay. And so if you're eating too fast or eating something large and too big, it can get stuck over here. And because of that, not only will you not be able to eat anything more, but neither will you be able to get any air in or out either. Okay. And so either there can be a blockage that's temporary, or it can be blockage that's permanent. And our hope is that we can learn some quick techniques to be able to move a blockage either up or down, hopefully out, so that someone can breathe again. Okay. And patients make, if someone's choking, you might hear a certain sound that people are having. People know that if you've seen someone choking, you might see them as holding their throat or bending over like this and saying they can't breathe, etc. And you might have just seen them, eat some nuts or eat something very quickly or talk while they're eating. That's why we shouldn't talk while we're eating either. If you suspect that someone's choking and something is stuck, they may not be able to speak, they may be coughing, you might hear some abnormal sounds in their breathing as well, and they can't basically cough it out themselves. Normally, a lot of us, if we're healthy and if it's small enough, we're able to clear our throat well enough. But if we can't, we might need someone else's help. And it can become an emergency, obviously. So this, like I said, is what a lot of people will notice or will witness if someone is choking. And in little children, that's very common, whether it's a small toy, whether it's some food that they're eating, if it's not, cut into small pieces. And they may not be able to tell you if they're choking or not, right? So as a parent or as someone, as an adult who's beside them, or even a teenager, you might be able to see someone who's choking. So what you want to do is, for someone who is under the age of 1, they're small babies, so you should be able to hold them in an arm. And what you want to do is you want to lie them down, face down, so tummy down, as you can see in the top left photo over here. And you want to give them 5 back blows. So you want to hit them in the back on the back fairly firmly so that you're able to dislodge whatever is stuck there. Okay, so when you bring them down like this, the reason why you're doing that is with gravity, it helps you. And also so that if the food does get dislodged, it doesn't go down further, for example, into the lungs. So that's why you have the baby down and you're hitting them at the back so that you're able to dislodge whatever is stuck there, whether it's a toy or something else like that. Okay, you do that 5 times and then you flip them over. So you flip them over then onto their back. And then you're going to press right over here, just below the sternum, which is the main breastbone over here, Just below that over there, you're going to press with the 2 fingers fairly firmly 5 times, again, to try and see if you can dislodge whatever might be stuck wherever it is. Okay, you do that 5 times in the back and 5 times in the front, and hopefully you'll be able to dislodge it. And if not, absolutely you should have someone else. So if you're taking care of the young child, you should have someone else in the meantime who's already calling 911. Okay. So this is an example of how you can do that. And if you can't hold someone, you can always rest them on your knee as well, and you can do the same thing. This is an example of where you'd press basically. For an adult, this is something called a Heimate Maneuver. So adults can mostly be standing up, or they might be lying down, but if they're standing up, you can actually stand behind them, and and when we do our stations, we can demonstrate it in terms of how you can actually help someone with such a maneuver. So whether it's a child or an adult, what you can do is you can stand right behind them. You make a fist first. So it doesn't matter if you're left-handed or right-handed. You have a fist and you place it again right below the breastbone, and you take your other hand and you place it right over your fist. And then what you're doing is you are pushing upwards and inwards. So in this direction here, you are going to push like that. Okay, and again, it's the same principle where you're trying to dislodge what might be stuck. And we'll get some practice going on as well, and hope not injure anyone. So this is the same thing in an adult. You can see here that this person over here on the left-hand side is choking, and then the person comes behind them, they place their fist, they cover their fist with their hand, and then all of a sudden they're going to forcefully push up and push inwards. And what that is going to help is this person who might have a piece of steak or something stuck in the throat is going to force them to cough it out. Make sense? Any questions about that? Okay, it's fairly straightforward. And what will happen is when we do practice, you'll get fairly comfortable being able to do that maneuver itself. And you can absolutely save someone's life that way. If someone is unconscious and you can't pick them up, for example, they might be lying down on the ground. And so what do you do there? So certainly if someone's on the ground, you can do the same thing, same principle where you're pressing forcefully down, same place, and you're forcibly pushing up, and hopefully you might be able to dislodge whatever's stuck. This is a diagram showing the same. What if you're all alone? What if no one is around you and you're choking, right? Everyone does this, right? It doesn't really help, and you hope that it either goes up or it comes out. What can you do to help yourself if you're choking? So you can do a self-Heimate maneuver where you basically find something around you, whether it's a chair like over here or something else, and something that you can push yourself against forcefully. Again, same principle, targeting the same part of the body, forcefully pushing in and up in this direction that will help you cough out whatever is stuck there. Okay, so you can lean over a chair or a countertop that might be around you and be able to do that for yourself. Okay, and and as we'll learn is if someone's unconscious and they've choked, etc., after you've dealt with removing the what might be blocking things, you have to start CPR, and we'll talk about how to do CPR and how to do it properly and how to do it effectively, because that's what's going to make the difference. We'll skip over COVID precautions, and the most important thing here is when someone is able to breathe now, don't blame the individual. I see this a lot where people are like, why did you eat this? Or why did you drink that? And that's, or why were you talking while you were eating, etc. I told you not to do this. Don't do that. It's not helpful, right? You've removed the foreign object. The patient, whoever is there is now feeling more comfortable. So now afterwards, you can talk to them about, okay, this is why we don't put toys in our mouth, for example, okay? So generally good preventative measures, have small bites, chew thoroughly, don't talk while you're eating, which is a good habit anyways. And then there might be medical reasons why, especially if you choke on a regular basis, right? If you have difficulty swallowing on a regular basis, go to your family doctor and see if you have, diabetes, if you have any ear, nose, and throat issues, or if there's muscular weakness that is causing you to have difficulty breathing and difficulty swallowing on a regular basis, especially if you have frequent choking episodes. Okay, that's not something you should be ignoring. And with that, what I'll do is I'm happy to take any questions very quickly, and if not, we'll move on to the next speaker. Any questions about that in terms of choking, what you should do if it's an adult or a child, and how you can help them or you can help yourselves if you're choking? No? Everyone's an expert? That's great. So we'll get to practice it when we do and I'll just quickly check online if anyone has any questions. Very quickly. Nothing yet. Okay, perfect. So that's great. So I will now pass it on to the next speaker, who is Dr. Obaidullah. Perfect. He'll talk to you about seizures and how to quickly recognize signs of someone having a seizure and what to do if someone is having a seizure. So without further ado, Dr. Obaidullah Khan.
Assalamu alaikum wa rahmatullahi wa barakatuh. Hope everyone's able to hear me. My name is Obaidullah. I'm one of the emergency doctors in Kitchener. Seizures are relatively seen, I wouldn't say as often as every shift, but definitely commonly enough where you don't really go a week without seeing somebody who either had a seizure or has some type of seizure disorder. Relatively common. And we'll go through some epidemiology, but there are some thoughts that I wanted to share even before I start. Basically, there's 3 points that I wanted to mention. Part of it has to do with like our understanding as Muslims of how we deal with different diseases and how we have to understand them. The one thing we know is that like the knowledge of medicine obviously is very highly respected within our deen itself, and even Imam Shafi'i said that after the knowledge of the deen, the most important knowledge is knowledge of the body. And so, you know, inshallah, for everybody sitting here and everybody attending online, it is an act of ibadah for all of us. Emergencies happen without warning. And so these things, I think even like an anecdotal story that I had is that even a good friend of mine who is actually an engineer, he ended up seeing a patient who ended up having, for example, a cardiac arrest. And he ended up being the first responder to be able to come and actually respond to that patient. And so especially when it comes to like, you know, the kind of respect that we had for people who were first responders during COVID, keep in mind that you can be that person. And sometimes you will need to be that person. And so it's really important that we start to recognize some of the signs and symptoms of this. What is a seizure? Incredibly common. It is the definition is sort of in the second point here. It's uncontrolled overstimulation of areas in the brain related to excess electrical signals. And because of that, people can have muscle-related complications. And so they might have stiffness for some of their muscles. They can have rhythmic jerks with some of their muscles. For some people, it may be that they're partially aware of what's happening. And so it may be that one of their limbs actually is going through a seizure, but then they're able to talk to you at the same time. And for some other people, it may be that a fever, for example, leads to it. And it's fairly brief. Incredibly common. It's about 1 in 10 people will have a seizure in their lifetime. We kind of like covered this, but basically many different types of seizures can occur. But the important point is that we are able to recognize these signs when we're able to see it. So what are some of the stages that we see of a seizure? So the person that's going through it, they may see bright lights, they may see some, smell some odd things. For some people, they actually actively have hallucinations when they're going through this. For many of them, they will be unresponsive. Even though their eyes may be open, you may notice their eyes rolling back. You may notice that their jaw is clenched and they're having a lot of saliva forming around their mouth. For some people, they even lose control of their bowel, their bladder. And so that's something they don't have control over. Often the person having a seizure will shake, but sometimes the seizure activity is more subtle. So it takes a lot of kind of like focusing on the patient. And after it is over, many patients will end up having this period of confusion. So medically, we call it a post-ictal phase, and that may last up to 20 minutes where they might be a bit groggy, a bit drowsy, but they're not shaking at that time. And so that may happen, and that is normal. When someone's going through an actual seizure, the important thing is that making sure that you yourself are safe first, that you yourself are not going to be tripped by the patient, you yourself are not you know, incredibly close to the patient. The important thing also is to make sure that they are in a safe place. And so like if there are any obstacles, any large things that might fall on them, if it's like a lamp that might fall on them, those things just have to be clear just so that they are allowed to be able to have their own space. If they're sitting on a couch, if they're on a bed, then you can ease them onto the floor just so that they don't have anywhere else to fall and hit their head. And this is one thing called a recovery position. And so incredibly important to know. We teach this even for patients who end up having a lot of alcohol and then they see their friend, for example, dropping inside a bar. They should be placed in a position where they're not going to be choking on their own tongue. And so what we do is that initially while the patient's lying down, you try to turn them on one of their sides. You take one of their arms and you place it underneath their neck in a position like this. Take the other arm and place it on the ground. And then their legs have to be placed in such a position where they're not flatly lying on their own belly or they're not flatly lying on their own back, in which case the airway can be a bit more compromised. The other thing is that for somebody who sees a seizure happening, there are a couple of things that I would wonder. Now, the one thing is, does that patient, or is it a friend? Is it a stranger? Do you know if they have a seizure disorder? Because depending on that, you can understand, how urgent it really is. Because if it is a friend who has seizures very often, and say it lasts a minute, then it's important to kind of ask them or ask family members what to do next. But if it is somebody who you do not know, you find a bystander, don't think twice, just call 911. We don't have time to figure things out. But for somebody who, like, you do have the resources, see if you can time how long the seizure is happening, because it's really helpful for us when we see them in hospital. If there's anything around their neck, such as a scarf, try to see if we can loosen it so that it doesn't tighten around their neck. Remove any sharp objects from the area just so that they're not hurt. And of course, call 911. I believe this video should work. If the audio is not working, if like on Zoom, if someone can let us know about that.
How to put someone in a recovery position.
Is everyone able to hear them?
If a person is unconscious but is breathing and has no other life-threatening conditions, they should be placed in a recovery position. With the person lying on their back, kneel on the floor at their side. Place the arm nearest to you at a right angle to their body, with their hand upwards towards their head. Tuck the other hand under the side of their head, so that the back of their hand is touching their cheek. Bend the knee farthest from you to a right angle. Now, carefully roll the person onto their side by pulling on the bent knee. The top arm should be supporting the head, and the bottom arm will stop you rolling them too far. Open their airway by gently tilting their head back and lifting their chin, and check that nothing is blocking their airway. Finally, stay with the person and monitor their condition until help arrives.
Any questions so far? I'll just quickly check the chat here, see if there's anything there. It's good. Sorry. And these are some things about not to do when somebody seizes. If the person is actively going through a seizure, try not to hold the person down to be able to stop their movements. We end up doing a lot more harm when we do something like that, especially if they have contraction motions and you're preventing their arms from moving out. You don't want them to have any injury associated with that. Do not place anything in their mouth. So for some people, they might salivate so much to the point where there's a ton of saliva coming out and it makes a mess on the floor. It may make people slip. At the same time, nobody should be putting tissue inside their mouth to be able to avoid any of this saliva from coming down. It's only going to make things worse if anything gets dislodged inside their mouth and they choke on it. Then you have to go back to the previous presentation. No need to give mouth to mouth in these situations, especially with COVID risks. It's not really something that we need to do. If obviously we are concerned about their airway, then we should probably call 911 and let the emergency staff kind of deal with their airway there. Do not give them anything to eat or drink until they are completely coherent. So as I mentioned, there is a small period of confusion for about 20 minutes. During that period, they should not be eating or drinking because they are not fully aware of what's happening. Some people mentioned, for example, like if you place a mask or cloth over the person's face, what can end up happening is that it helps them being able to breathe, and you can at least see that they're able to breathe in and out, and that it's not too tight. Of course, if you feel that it's going to be similar to the issue of having a scarf around your neck and another compromise for their airway, then you don't need to do that. And wear gloves if possible, just because there is going to be a lot of saliva, and there may also be, as mentioned, they may lose control of their bowel and bladder. And so just good to kind of keep sanitized and ensure you wash your hands after help arrives. Any particular questions about that? Yeah, and so it kind of depends on like how they're presenting in terms of like those rhythmic jerks that we were talking about. Not every single time is a person who's choking going to be unresponsive. In severe cases, they will be. So the universal sign that we teach in first aid is that if somebody's choking, then they should be doing this sign. then obviously there's that. Obviously, if they're eating just before it happens, more likely for it to be a choking episode. With a seizure, typically they end up having those rhythmic jerks that we talked about. And so there's like the clenching of the jaw and the clenching of the hands and fists. And then they might have like rhythmic jerks that are associated with that as well. And they're usually unresponsive. But of course, if you have any doubts, is it one, is it the other? It's not our job to try to figure it out. Let's just call for help.
So, critical identification either happening, like in medical itself, within a certain amount of time, or
Yeah, so that's a very good question. And so, yeah, for sure. My apologies. The previous question actually was related to how to differentiate between choking and a seizure. And so that was the question I was answering. The next question is related to time. So a time limit, like when should we be worried? And so the classic definition for us from a medical standpoint is 5 minutes or multiple seizures within 5 minutes. And so for somebody who, for example, has a seizure within a minute and then it goes away, it's still not wrong to call 911. But if they are somebody who deals with seizures all the time and they tell you, it's fine, obviously it's a little bit different. But if it is beyond 5 minutes, then at that point we have to give some medication to be able to calm it down. And usually it's by medication. And so we'd have to bring them to hospital, either give them something through their muscle, something through IV. And so that would have to happen to kind of calm the seizure down. Any other questions? Yeah. Great question. Especially when they're having those jerks, should we be putting them back in the recovery position? And so if those stiff movements are obviously like happening to an extent where it's preventing you from putting in that position, then you don't need to. That's mainly for the time when, for example, after they have stopped seizing and they go into that period of confusion and you want to make sure that their airway is preserved, then you can. But if you're noticing that it's a little bit too difficult, then you don't have to. Anybody else have a question? And so I'll probably end on basically the advice that, of course, if any of these emergencies are happening, then especially when there's obviously like we're not really aware of what the patient's kind of going through, nothing wrong with calling 911 at that time. Seizures can happen from many, many different causes, and it's not always something that leads to long-term damage. And especially with very young children, some parents may remember if their child ended up having something called a febrile seizure. And so that just goes to show that many, many different things can cause a seizure. Not every single cause is a very worrisome one. But usually in these cases, it's not bad to get medical advice and even come to the hospital if you're still worried. Oh, okay. If someone has lost his or her consciousness, how can we differentiate between a seizure or a heart attack? And so a very similar question to, I guess, like even trying to differentiate between like a seizure and a choking episode. Sometimes it can be a bit hard because when we were talking about the symptoms of a heart attack, one of those symptoms can be unconsciousness. And so they become unconscious because they had a heart attack. For some people, they become cautious because they had a seizure. So at that point, for those who obviously have taken the training within first aid and they know that the patient's unresponsive, there is no pulse, that's a different pathway. But ultimately, if you find that it's not completely clear, because we talked about some of the typical signs and symptoms, patients with seizures don't typically have chest pain. Patients with seizures typically won't have shortness of breath right away. And patients with heart attacks won't have rhythmic jerks associated with them. Those are some typical signs and symptoms, but there are always exceptions. And so ultimately, it's those are some ways that you can differentiate, but it's not always perfect. Hopefully that answers the question there. Oh, perfect. I'm just put that in. Awesome.
I'll get started.
Thank you so much.
So I'll get on the next slides, which will be the CPR and AED. And just in response to that last question as well, when in doubt, the last thing you want is to miss somebody having a heart attack, or cardiac arrest is probably a more appropriate thing to say. So you should probably just make sure that that's not what's happening, because seizures rarely ever kill you, but a cardiac arrest will certainly kill you. So, but I'm biased. I should fully disclose that I'm biased towards cardiology and cardiac issues. All right, so let me, yes. Slideshow. Okay, so for the last session of this afternoon, where we're doing a didactic or more of a large group session, I'll talk to you about CPR and AED, and Dr. Sabah is kindly going to help with the session as well, in terms of demoing the actual AED before we take a short break of 10 minutes and then go into our breakout rooms, small groups. So I'll be talking to you about the CPR and the automated external defibrillator, which is the AED. And so just to take a quick overview of what we'll be discussing here, the first is the theory. First, we'll talk about the aim actually as to why this is relevant and important. Next, we'll talk about the theory and then the demonstration itself, and then we'll go from there. So the aim of this obviously is a community outreach program, as we talked about in the introduction, and we're targeting individuals that have not really been exposed to CPR. Before I move on, and this is a great question by Dr. Naqvi here, but has anybody ever seen somebody have a cardiac arrest or had to be involved in doing CPR? Nope. Does anybody know somebody who's had a cardiac arrest? One person, that's it. Does anybody know that if somebody's passed away or survived? Like, the reality is, to be honest, the number one killer of individuals is heart attacks. And the number one reason why people with heart attacks die is typically a cardiac arrest. So whether you know it or not, if somebody just said, oh, they died of a heart attack, the reason people with a heart attack die is because their heart stops. The reason their heart stops, as Dr. Naqvi very appropriately put, is that there's a lack of blood flow to the heart, so it's no longer working, right? So actually the response here is everybody knows somebody who's had a cardiac arrest. If you know somebody who's passed away in here, by definition, they've died, right? So it's it wasn't meant to be a trick question, but I guess it turned out to be. But the reality is that if you do happen to come across somebody who you recognize as having a heart attack, if it's not fixed quickly enough, the natural progression of that, typically in some patients, is that their heart will stop and they'll die. They have a cardiac arrest. That's when these things become relevant. That, at that point, when their heart has stopped, usually due to a blocked artery, what can we do until they get back to the hospital and somebody is able to go in and open up that artery instead? Okay, just so we understand that cardiac arrest is the most common reason why people are dying, and the most common reason for cardiac arrest is a heart attack. All right. So why do you need to learn about CPR? So as I said, cardiac arrest just primaries cardiac reasons, not because somebody was sick from an infection and their heart stops. Because technically, if we want to be technical, again, I'm biased towards cardiology, people are passing away when the heart stops. So technically all deaths are related to cardiac arrest, but I'm diverging a little bit. So we know primary cardiac issues where the heart stops only because of a cardiac issue, about 40,000 at least per year in Canada. And we know that we have many more heart attacks as well that are associated and occur. Majority of these, about 85% of them, are happening in public areas or in your own homes. And we do know that people that have cardiac arrests at home or outside the hospital are they're less likely to survive, especially if they don't get something called bystander CPR, meaning us happening to be at home with no drug. Even if I'm at home, like I don't have any medications or IVs or anything, but what I'm teaching, or what we're teaching everybody here, is that basic of bystander CPR until somebody like an EMS, like a paramedic, can come and do whatever they need to do. So majority of these happen to be at home. And we know that for every minute that passes, you're surviving without CPR. So let's say somebody's unresponsive on the ground and you just found them. For every minute that you're wasting thinking about what to do, there's a 10% reduction in their likelihood of survival. And so somebody who's been found having been unresponsive for 20 minutes and nobody did CPR, they're extremely unlikely to survive. We're talking in the single-digit survival, okay? So, but sadly, as a cardiologist, we often see in the hospital, people come in as out-of-hospital cardiac arrests. The sad reality is that in many of those cases, I would say, unfortunately, more than half, the family members didn't think to check a pulse and didn't do anything before they got in touch with 911 and until EMS arrived. And so you can imagine, we talked about the stroke example, we talked about the heart attack example, there's irreversible damage happening for every minute that this artery is fully blocked. So every minute that we waste is time and muscle and brain, but also drastically reduces the likelihood of survival. So I cannot stress this enough. And that's why I added to the last question that I'm unsure, is this a seizure or is this a heart attack or is this a cardiac arrest realistically? A heart attack, somebody will tell you, my heart is hurting, I'm about to die, I feel like I'm gonna die, right? Like seizure, people are less conscious. Cardiac arrest, they're completely unconscious, they're not breathing, right? So of these, that cardiac arrest is when people are dying. That is, they've actually died. Sometimes people get scared, like, hey, I don't want to touch a patient and maybe hurt them. I'm going to break their ribs. They've already died. There is no more harm you can do to them than what has already happened. They've already died. So anything you do on top of that, whether it's even a few beats of CPR, getting an AED, is something, right? It's still, you can't hurt them more. They're already dead. Now, if they say, oh, you did CPR and inshallah, they survive. And they say, oh, you broke my ribs. Yeah, that was a necessary evil for you to survive because you were literally dead by all intents and purposes. So hopefully I'm getting that point across that we shouldn't be afraid to do these things and we should do them as soon as possible. Now, if I happen to be on the ground right now and I'm like drowsy, but I'm like, hey, get off me. Don't start doing CPR on me. I'm clearly talking to you and I'm moving around. So this is not a situation where you say, hey, Hassan, you were on the ground and I want to start CPR on you. Obviously, it's for unresponsive people who are not breathing. And if you know how to check the pulse, then you'll check the pulse, right? So hopefully that makes sense. Hopefully that makes sense. So just to say, it's a very common situation. There's different reasons, most commonly, obviously, the heart. Most of them happen outside of the home, in which case we are all responsible for ourselves and our community and our family members. And for every minute that we delay, we unfortunately increase the likelihood of death. So in terms of just a chain of survivals that are included, so you ideally want to recognize things as quickly as possible and call for help, okay? And so this is hopefully going, if somebody has a heart, like let's say they say, oh, I'm having chest pain. This is not where we sit around and say, okay, have some aspirin and have some garlic or something like that. When somebody's telling you something like this, especially within our community, and I think we have very stoic or very much like, oh, it's nothing, like we minimal, again, I speak with being a part of the community and also parents and siblings, what have you, we tend to minimize things often. We're not like those patients that jump to the hospital any chance we get. We tend to minimize things a little bit. But if somebody's telling you, I'm having chest pain and this is not normal for me, do not wait to figure things out like, oh, I'll sleep on it. Every minute, every hour, every minute wasted is muscle weight being wasted, and it can transition into a cardiac arrest, as I said earlier. So if somebody says, hey, I'm having chest pain, call 911 right away, early recognition, hopefully prevent the cardiac arrest from happening. If, God forbid, you do happen to come across somebody who is unresponsive on the ground, then that's when we're going to go through the algorithm of calling for help or telling somebody else to call for help, getting an AED or telling somebody else to get an AED, and then starting CPR immediately. We'll talk about what to do if you're in a group like this, or if you're all alone with the unresponsive person. We'll talk about all of that. So CPR, cardiopulmonary resuscitation, that's what it stands for. Cardio meaning heart, pulmonary meaning lung, resuscitation meaning we're trying to resuscitate somebody who has unfortunately passed away. There are different types of CPR. There are CPR that are hands-only CPR, which is all you're doing is chest compressions. You're not giving any mouth to mouth. And then there's classic CPR where you do 30 beats and then a breath, and then 30 beats and breath and breath. During COVID, recognizing that there's apprehension or people are worried about the transmission of COVID, most, if not all of the major societies have said actually stick to hands-only CPR. And there are also other factors or other things they've put into place to mitigate the risk of spread of COVID as well. So we'll get into that in a second. But just to say, what we're teaching you wasn't necessarily what we were teaching 3 years ago or 4 years ago, because usually it's 30 compressions, breath, breath, 30 compressions, breath, breath. But now it's just keep doing as many compressions as possible. People might say, oh, like, we're giving old blood to the brain. That's still better than nothing, I assure you that. The amount of oxygen in the blood is sufficient that even if all you did was CPR, there's still enough getting to the body because the blood will still have enough oxygen because it's not like there's a lot of oxygen requirements of the body. Your body requirements for oxygen are dependent on cell activity. But if you're dead, or if the person is dead and not alive, then there's not a lot of activity. So there's not a lot of oxygen being sucked out. But you just want to make sure that the brain has a sufficient amount of oxygen whenever it needs. Okay, so just to say that hands-only CPR still completely reasonable to proceed with. And both are effective, as highlighted here. So it's as easy as ABC. So we typically will look at the airway, make sure there's nothing obstructing the airway. Sometimes, choking can also cause cardiac arrest. So we should put that out there for the respirology amongst us. But if somebody's choking, eventually if there's a lack of blood flow, oxygenated blood going to the heart, it'll stop as well. So if there's an obvious obstruction, we're going to obviously remove it. If somebody's, against the ground and not breathing, we're going to remove any sort of obstruction that may be there. Breathing, we want to know, are they actively breathing? Like, is their chest moving up and down? You can sometimes get close to them and see if there's any breath moving, if various things. You can put your hand there to see if you feel any breathing. Sometimes people can use like a glass next to the nose, because when you blow out, typically you'll see some condensation on the glass. So there's different ways, but in general, get an idea of whether they're breathing. Again, if you're unsure, nobody will ever fault you for trying to save somebody's life by doing CPR. Okay, so I mentioned these things, but nobody will ever fault you to say, oh, you did CPR when it wasn't necessary. You would rather that than a situation where you could have saved somebody's life by doing CPR and chose not to do it because you weren't sure. When in doubt, you should do that. You know what will happen if you start doing CPR and somebody's alive? After the first two, they'll be, get off me. Like, what are you doing? You will know right away that they're actually completely alive and you don't need to do another beat. But if they're not, that should be a pretty good indication that there's something going on, okay? And then circulation, typically there's different ways that we look at this. Now, if you see somebody who's completely blue or white skinned, like that might, they're not usually like this. They look like they're not moving, they're stiff. Like clearly, that implies that they may not have a heart rate. We will typically, and we can talk about this, this is not the purpose of this particular talk, but when we typically come to somebody under the thumb, you can check your own heart rate as well, under the thumb in the wrist. If you push in there with your two fingers here, you'll feel your pulse. You can also do the same thing under your jaw, and you can practice on yourself. There's nothing, there's never an issue in practicing on yourself. And if you can feel your own pulse and you're looking around and somebody else can't feel it, clearly they probably don't have a beat. But again, if in doubt, don't waste your time, like 5 minutes checking for a pulse. Just start if you're in doubt, okay? So in terms of what to do when you find somebody collapsed on the ground. So what are you gonna do? So let's say, God forbid, something happened here, and let's say there weren't any physicians. What would you do? You could certainly check the pulse if you know how to check the pulse, yeah. You could certainly look at the body, but that's why we talk about the ABCs, right? So that's an approach we want you to remember. That stands for something. So as you said, check a pulse, which is circulation. Again, I'm biased, but also this is probably good. We should probably check circulation first. So it's CAB. But all in all, it's to say that you want to see, do they have a pulse? Do they look like they're responsive? Is there anything in their airway? Are they breathing or not? Quick ABC. It shouldn't take more than a couple of seconds to figure that out, right? And so at that point, we're going to talk about what our approach is going to be, but that's a great first thing. Before we start doing anything, you may happen to come across somebody outside. There might be live wires and electricity floating around, and maybe the reason the patient or the person is unresponsive is because they got electrocuted. The last thing we want is to go from a single person who's had a cardiac arrest to a second person, which is you trying to help them because you got electrocuted. So the first and foremost thing that we teach is you need to make sure that the area is safe. I'm not sure what that is. Sorry? Oh, okay. I was just like, what? Do I need to go do a cardiac arrest situation here? Like, is there help needed or what? Okay, so as said, so safety is first and foremost for yourself, right? So one victim better than two. So there's no fire, there's no wire, there's no gas, there's no glass. Everything is safe, hopefully, for you. Once you've ensured that it's safe, that's before you do anything. That should not, even if it's unsafe, that shouldn't preclude you or stop you from calling 911 and getting help, right? So when you first get there, you say, hey, are you okay? Hey, what's going on? You can often typically rub them in the front of the chest, this bone, the sternum, which you can feel on yourself as well. It's the strongest bone in the body. So you can push pretty hard here, and people will feel discomfort when they wake up, or you can, squeeze their fingernails and see if they wake up. Or there's a trapezius muscle here, which is kind of like right in between the shoulder and the clavicle. You can squeeze that. You squeeze it on yourself, you're going to feel it. You're going to be like, ow, that hurts. The purpose of you checking for a response is if, despite you going at it and like pushing on them and causing them pain, they're still not responding, that should be an indication that this is a serious situation. This isn't just somebody kind of hanging around and just on the ground doing nothing. So as we said, sternal rub, you can squeeze the fingernails, you can squeeze the shoulder, like the area between the shoulder and the clavicle, which is the trapezius muscle. You squeeze that pretty hard, you'll see. You can do whatever, like so long as its purpose is to check for a response. Those are the areas that are probably most painful on you. So that's why we typically will advise that. And if you're not seeing a response and it doesn't look like they're normally breathing, most people will breathe about 10 breaths a minute or so. And if they're not getting that, then you need to call for help first and foremost. This is not when you're like, you know what, I'm just like, if you're all alone, the last thing you want to do is just be all alone and doing CPR without calling for help. This is very different from a Heimlich or something like that. Most people, as I will hopefully demonstrate to you guys, is when you do CPR for a few minutes, you're tapped out. It's a pretty intensive situation. After you do it for 2 minutes, you're like, my arms are sore, my shoulders are sore. So you are only going to be able to do it for a limited amount of time. So you need to have people coming in for help. And if there's other people around, there should hopefully be people who can cycle in to help do CPR. Okay, that's why calling for help is so good. So make sure there's safety, calling for help. So if in here, you'd say, hey, we have somebody who's down. Bystanders, people who are around, come and help me. What does that mean? Oh, that means, sir, please call 911. Ma'am, please go find our AED that we have sitting around somewhere here, which is present in most public institutions. And then, other people, hey, can you get me a cover so we can cover the mouth? And then let's start CPR right away and go from there. Okay, so you want to call bystanders nearby to help you, call 911, get an AED, which is the automated external defibrillator that we're going to demo very shortly. Get that on site as quickly as possible. The automated external defibrillator is as easy, I'm sure even the children in this audience will easily be able to hear and listen to what you're supposed to do and follow the responses. This is not some high level technical thing. It's literally pads you put on, electricity that gets delivered. It does all the work. So we're going to demo that. So please, if there's anything you take away from here, it's the CPR, AED, the importance of those. So when we're talking about adult chest compressions, so typically, again, we talked about the fist for the person who's choking like this and the hand on top. But for somebody who's doing CPR, you'll typically take, you can use whichever hand you want, but I usually use my right because I'm right-handed, like this, and then put your fingers through and then make a fist. And this heel of your palm should be right in the middle in the sternum that we felt that we're going to be looking for. Hey, are you having any sort of response? Well, over here, you're pushing, that's where the heart is in around there. And you really want to create this, I guess it should be on camera like this, and then fist like this, and then this part over here that you're going to be using to push down. Now, people will say, well, how fast am I supposed to push down? About 100 to 120 minutes. Luckily for us, the AED actually has like a tick, 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 a metronome that tells you at what speed you're supposed to go. Otherwise, there's different things like there's like that ABBA song, Staying Alive, that often is quoted. So, you can use that in your head just to make sure that there's enough heart rate going. I'm doing this with my elbow bent. That's obviously not the right technique. We're going to talk about that in a second as well. When you're pushing, you want to go at least 2 inches deep. So that's like about this deep, right? So that's it's a good distance that you're going down. It's not unusual, as I said previously, for some of the ribs to potentially break. But as I said, these are situations where life and death is occurring. If you don't do this, they will die. They are technically already dead at that point. So all you can do is help. Okay, so it should be at least 2 inches deep. And you are usually using your weight. And we're going to demonstrate this shortly. You're using your weight. So you're not using your elbows being bent. You're literally like, if I'm going to stand up here, it's like this, and you're doing this. You're not doing this. This you're going to tire out very quickly. So you're literally, like this, and using your weight to push in and out. And you want to allow the 2 inches to eventually come back out. So once you push, You don't want to do this, right? You want to do 2 inches out and then give it space to fill up with blood again and pump. Remember that the heart and the vasculature, the vessels, the blood vessels are all connected. So for every pump you give, blood goes forward, but it still needs to come back to pump the next amount of blood. That's why you pump and then you recoil to let it fill up again and pump again. Okay, so hopefully that makes sense as well. So with children, the technique is a little bit different. You're going to use 2 fingers. Hopefully, God forbid, this never happens. Obviously, it's exceptionally rare for a child to have a cardiac arrest, but still, if it does, you can either use a hand, like a single hand and push, or with a baby, you're going to use 2 fingers and similar rate of 100 to 120. This is an example of an infant. So in this case, you're using 2 fingers, and hopefully you're going to, in the same spot, the sternum, right in the middle of the breastbone, just push right in there. And then with not infants, with toddlers or with kids, you're going to use just 1 hand. Obviously, if you have a child who's 12 but happens to weigh 300 pounds, you're going to use regular, chest compressions. During COVID, you don't necessarily give breaths. Historically, we used to give 2 breaths after 30 compressions. It gives you a bit of a break. Also, hopefully gives a little bit of oxygenation, but we don't do this during COVID. But when we used to do it, we're going to give breath, usually lift the chin up, pinch the nose. The only place the air could go is down out, and then have a covering of some sort and blow in. Like I said, even hands alone is still fine, effective. And during COVID, this is not recommended at this time. But I just put it in there so you don't think that I'm like making stuff up and taking things out or whatever. Yeah, so that's an example of what you're doing, and you're looking at the chest to make sure that it rises. All right, so when to stop. This is pretty important as well, because like I said, if I'm fighting you to get off me and you're like, no, I need to do my CPR, and if I'm talking to you or if I'm responding and clearly moving around, somebody who's had a cardiac arrest is not moving around, right? Like they're dead. It's somebody who's not alive. So if you have somebody who's moving their body or starting to breathe and groan, that's somebody who's obviously not, still in a cardiac arrest situation. Luckily, you were able to save them, or luckily you didn't need to initiate CPR. And so that's typically when you would start or not start. So if you stop, if the patient starts breathing or starting to say something, or as we said, let's say all of a sudden we're in some sort of a movie situation and something happens, something falls, it's no longer safe to be around there. Again, we're not looking to have 5 victims or people that need help as opposed to 1. So if things become unsafe around you all of a sudden, again, this is not the time to try to be a hero and continue CPR at that point. So let's say you found somebody, you assessed them, they did not have a pulse, you started CPR, called for help, and AED gave a shock, all of a sudden they're breathing, they're talking, and they're good. So what are you going to do now? So we reviewed this a little bit with the other talks, which is the recovery position. And it is an important position, not just because we like to put people in a certain way. There's a reason why we do this, right? So we want first and foremost the person not to be aspirating, meaning their stuff in their mouth shouldn't be going in their lungs, because we might get issues, whether infections or obstructions. We also don't want the tongue to roll in the back of the throat and they swallow it by mistake, and then they have an obstruction that you need to clear, and then again they stop breathing. So that's why we move people on their side. And we use their own hand, as you see in this diagram. So this lady's hand is being put on the opposite side, then she's being turned over to the side to hold her head with that hand. And as you see that she's on her side, so hopefully nothing goes in her mouth, and her neck is tilted to open up the airways to ensure that the breathing is okay. So really important, but to be honest, hopefully by this time help has arrived and they're being managed by your paramedics. Okay, so that's a lot of content, and I'm fully cognizant that I tend to talk fast. So are there any specific questions about the CPR? Oh, thank you, Shannon. Faiza has asked, why should the mouth be covered? And I'm assuming that this is in the context of CPR. And so the thought is, if somebody may have COVID or some sort of other infectious situation, whether it's the flu, whatever, they might have something. So we typically will cover the mouth just to avoid, because every time you're doing chest compressions, they're breathing to an extent as well, or air in their lungs is getting pushed out. And so if they have COVID and the reason they collapsed is because they had COVID or some sort of infection, now you may be getting exposed. So that's why the things change to go ahead and cover their mouth and nose. So then they're reducing the risk of transmission. So that's why their mouth should be covered in the current context and climate. Again, this is a change in the last couple of years. Before CPR, yeah, it's the same question. So yeah, that's the thought process. Again, am I gonna be like, hey, I'll be right back? I'm not gonna be like, let me go find something. No, we can just take some sort of a mask that all of us are wearing and carrying nowadays, or take their shirt and put it over their head or something. It doesn't have to be rocket science. Just keep it as straightforward as possible. That the key is to start CPR as quickly as possible. This is to hopefully prevent you from getting transmission of anything, and also to reassure people to say, hey, we are thinking about these things, so you don't just automatically think we just want you to put your life on the line, even if it may be endangering you. So these are just some of the thoughts that have gone into this. All right, so let's go ahead and remove that. So if nothing further, and I'm going to hopefully try to move this out of my way. So next is the automated external defibrillator. So I'm going to initially go through some of the lecture stuff, the didactic stuff, and then we'll get into a demo and then hopefully get into this groups thereafter. So an automated external defibrillator is something that's pretty much available any community center, any public area, and it's an easy to use device that gives step-by-step guidance by the machine itself. Okay, so these are the prompts, and I'll ask Dr. Subaj possibly come up and we'll just demo it on the mannequin as we're going. But let's say somebody brings the AED to you and you're like, okay, what am I supposed to do? Well, you're going to go ahead and open up the AED. Oh, I guess, yeah, that's a good idea. Do you mind if we, okay, perfect. Thank you so much. We're just going to move the camera and that should be sufficient. And just, yeah, that should be okay, I think. Oh, you can see it as well. Perfect. So you're going to get the AED and you're going to open up the packet. You're going to turn it on, and pretty much once it's out of the box, as you can be demoing it, and you can, for the people in the on virtual, you can actually see the yellow one. There's a big power button that I'm circling on the mouse, and Sabah can also do it live, and just click that button. So this one has a child option as well. So in this case, there's no clothing on the chest anyways. It's asking you to put the pads on the patient. So it tells you where to put the pads as well. Remove packet and apply pads on the patient's bare skin. Okay, so we're going to put the pads on at this point. And it'll keep saying this until you do it. Remove packet and apply pads on the patient's bare skin. Press pads firmly on skin. Apply pads as shown in the picture. I think that should be sufficient. Apply pads as shown in the picture. Press pads firmly on skin. Let's just hold it, maybe. Maybe there's one that's not entirely on something. So in short, like I said, it'll keep going until it's happy, because it needs to actually measure the electrical activity of the heart to then determine what to do. It's not requiring you to do anything. So pretty much once you remove the electrodes and put it onto the chest, it's going to say, then you are hopefully going to continue to futz around like we're doing right now. Sorry? Yes, I think there is some panic going on right now. I'm just joking. I'm just joking. Okay, so it seems to. So now in this particular case, shock delivered. Begin CPR. Perfect. So as you see, it's actually, you can hear the tick, tick, tick. That's when you're supposed to be pushing and doing CPR. It's actually counting it out for you for 10, 20, 30, 40, etc. We could probably just turn that off, and we'll just recap for everybody, including those that are virtual. So pretty much you get the AED, Usually, I think obviously the pads and the mannequin need to be in our case, but usually I've never had an issue unless somebody has a very hairy chest. And that does happen, in which case actually the AED comes with a razor as well that you can clear the area where you're going to put it on. Now, as you can see on the pad in the presentation as well, and you see on the AED itself as well, it tells you exactly where you're supposed to put the pads, right? One here, one here. Once you put that on, it says, don't touch the patient, just leave them because it will analyze the electrical rhythm of the heart, okay? Based on that, it determines whether the rhythm is the type that it can zap or it is not. Not that every time an electrical like it shocks you, just so we're clear, not all cardiac arrests are shockable. But this, if it is shockable and you can shock them, drastically increases survival rates, okay? But you may put this on and it says, no shock advised, start CPR. So just to say that there's two options here, right? So if it says, oh, it didn't shock, I don't want people to be like, oh, okay, I guess the machine isn't working, it didn't shock. No, no, no. There are truly situations where a shock should not be given. So long and short is that you're gonna, to get the AED, you're gonna turn it on, it's gonna tell you to remove the blouse. I guess we have one in the back as well. It's really asking for a shock on the back. So you're going to remove the electrodes, there's sticky material. You're going to put it in the area as described on the packages themselves. You're going to let them analyze it. Don't shake the patient. Don't touch the patient, anything like that at that time. You're not doing CPR at this time either. And then it very quickly recognizes if it is or is not something that shock is going to be given. And then as you saw, it said shock advised. And then it starts ramping up and then starts beep, 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 beep. And there's a red button there as well. That's going to be flickering like red. So that you want to make sure it says don't touch them. Because if you touch them, like let's say you're like, oh, let me touch them, well, you're going to get shocked as well. Then you may have a cardiac arrest as well. So when they say don't touch them, it's not just for, oh, for the technicality. Truly, there will be electricity going through them. You don't want to be touching the patient. If there's no shock advice, continue CPR until the next time the AED says, we're going to do another check. So it will check every 2 minutes. That's why it's counting the time, 10 seconds, 20 seconds, 30 seconds. After 2 minutes, it's going to actually say, advise to recheck the rhythm. And we're going to play around with that in the background. So I don't want to waste too much further time. But just to say, this is truly, truly life-saving, and all major institutions have it. That you can go to any community center, any mall, any apartment building, they'll have an AED. All right, so during the COVID times, which fortunately, hopefully we're coming out of, hopefully, inshallah, we're going to pray for that. But during this time, rather than we're not going to get right up in their face and listen for a breath or feel for breath, you're just going to shake, shout, and observe. You're going to prevent contamination by covering the person's mouth, whether with a mask or a cloth or something like that. And we're only doing CPR. We're not doing any sort of rescue breaths like we talked about with the 2 breaths after 30 seconds. And as we said, the hands alone is sufficient and good enough anyways. And of course, we're still okay to use AEDs. This is from the Heart and Stroke Foundation. So just summarizes things, and hopefully in some of the documents that we'll give to you guys as well to take home as well, or send to you via email, we'll have many of these instructions as well. So pretty much first thing you do is show up, call 911, shout for an AED if somebody else is around, prevent contamination by putting clothing or some sort of covering over their mouth and nose, push hard and fast in the center of the chest at 100 to 120 beats per minute, and don't stop until somebody else comes and gets help. And if you can get an AED, then you want to get that sooner than later. So that's pretty well just summarized in different boxes. But as highlighted here, really, you need to practice. And that's the whole purpose of the second hour or so of our workshop. And then just another summary, unresponsive, not breathing, active, call 911. Hopefully somebody goes to get a defibrillator, start CPR, and this defibrillator would be asking you to do CPR and checking the rhythm every 2 minutes. And cycling that every 2 minutes. All right, so that's the end of the lecture sessions. So we'll go ahead and take maybe a 5 to 10 minute break as we get things set up. If everybody wants to get, sorry, that's a great point. We should probably take maybe 5 minutes of question and answers. I see a hand up in the back there as well. So the question asked is, if the pulse is weak, should you do CPR or not? That depends on how reliable you think your ability to check a pulse is. So if you think you're confident that they have a pulse and they're breathing, you should not be doing CPR on that person. It's only for people that are unresponsive. You're squeezing them in their, parts where you're causing a lot of pain, they're still not responding. Those are the types of people that you want to do CPR on. You should not be doing CPR if you feel a pulse, if they're breathing and groaning and looking around, and that's not the person to do CPR. CPR is for people for cardiac arrest. If you're unsure because you're not confident in your pulse check and they don't look like they're breathing, then the safest option is to start CPR. Yeah. Cardiac, so the question for that's asked is, as a layperson, what is a cardiac arrest? So as maybe I won't go back, but as mentioned, so cardiac arrest is your heart has stopped. Cardiac arrest is your heart is not pumping. That's it. So that's a cardiac arrest. It stopped. There are many reasons for why that is. The most common being a heart attack. So that's why we're talking about how when somebody's having a heart attack, you don't want to waste time thinking, oh, I'll go to sleep, I'll sleep on this, give me some milk and some whatever. That's when you go to the heart attack, because if you don't deal with that quickly enough, it'll convert into a cardiac arrest, meaning there's so much damage that the heart stops. That is a cardiac arrest. The heart stopped, is not pumping. Yeah, good question. Yes.
I was just wondering to clarify or talking the nose and mouth, like
Yeah, just to be clear. So it's not like where you are like, have a hand on their mouth and nose. That is not what's being implied. It's literally just putting a soft covering gently over their mouth, just so if there is anything that they're going to spit up if they wake up or something, that they're not going to spit up all over you, right? So this is not like, we're not like, tightly putting something down or making sure that even if they wanted to breathe, they can't breathe because you block every mechanism for them to breathe. It's literally that you're putting a mask on or just a sheet over their face just to avoid them from kind of contaminating you. If there's a scarf, just put the scarf over their face, just gently covering it. But that's, thanks, good point of clarification. I just want to make sure that there aren't any questions online as well, because I know that we had some, but let's see. It doesn't look like we have any other questions before we kind of take a 5-minute break or so to assemble into groups. Yes. So the question is, if somebody's choking 3 to 4 times a week, if you're choking 3 to 4 times a week, you definitely need to go get that checked out, because that may imply there may be a medical reason, as Hashim had put, that there may be a reason. So choking, though, remember, is different than, once in a while water goes down the wrong hole. Choking is like you can't breathe and somebody's having to do, Heimlich, but even still, food is going down the wrong pipe 3 to 4 times. That's still pretty frequent, that it should be informed to somebody, especially if that wasn't normal for you before. Right? If you weren't choking before, but have now started choking all of a sudden a lot more, and it's happening regularly, consistently, that is something you should seek medical attention for. All right. So why don't we take a 5-10 minute break? So it's currently 12:43. So why don't we say 12:50? We're going to start. That's 7 minutes or so. And if we can just get people to get into groups of, I don't know, like 6 or so. We want 6 groups in total. Sorry? Oh, yes. And the virtual section of this would be wrapped up. If you have any questions, obviously, you can contact us. Let me just raise this here as well. And so for the virtual people, if you have any questions, you can obviously post here, you can message us. You can reach us in whatever way, and we can address that. And Dr. Amjad, who's one of our physicians in Muslim Medical Association of Canada, and also our vice president of MMAC, she's also online, And if there's questions, she may be able to address them. If not, then she can always pass them on to us. We'll also be sending a mini survey just on whether you found this session useful. And so that'll also give you another opportunity to connect with us as well. So thank you so much for joining. We really appreciate it. And hopefully you learned something. Of course, we're welcome to any feedback that you may have. Inshallah, we hope to do these more frequently and hopefully host more people in person. It does look like a completely sold out event here. And so it seems like there is a demand. Inshallah, we will do more of these in the future. So that's pretty much it. Thank you so much for joining. Assalamu alaikum.